what blood donor is quite, it's important that our blood donor base doesn't just match the UK population, but that it matches the population for demand. So a big source of blood demand is in managing conditions that require chronic blood transfusions, so repeated blood transfusions. An example of that is sickle cell anemia. So it's really important if you're receiving multiple blood transfusions that that blood is matched as closely as possible. And so that condition is much more common in the Black community, so it's really important that we get more Black donors. Which brings us to our problem, which is essentially we want to optimise the flow of new and regular donors to meet our donor base and blood collection performance targets. So these don't sound like on the surface that they would be an issue because they're kind of different things, but new donors present a variety of operational challenges. So for a given appointment, so you need more appointments per kind of blood unit for new donors. So they need more time on session, they're much less likely to donate blood, and we don't know their blood type. So it's difficult to manage stock. So they present some operational challenges, and this would be fine in the context of a system with a lot of give. But at the moment, you would have probably noticed, particularly if you work in elective care, that we recently had a blood stock crisis. So we're in a system where that was specifically for O-negative blood stocks. So we're in an environment at which we are struggling to meet demand. So it's really hard to find that extra bit of resilience to bring these new donors through to meet our growth and diversification targets. The reasons this is a difficult problem is blood is a complex system, and I'll dip into what that means, but it generally means it's hard to know the short and long-term impacts of actions. As I said, new donors have specific challenges, and we have other kind of operational constraints. So blood only has a 35-day shelf life, so you can't just kind of store it, and you can't over-collect and just pour it away. It's very, there's no waste tolerance in the system, rightly so, and it's hard for us to predict demand. So there's it's more difficult to know exactly what blood we need at what time because of blood matching. So what we'd normally perhaps traditionally do, sorry, this is a bit of a wordy slide, is we would think about things in our functional silos. I think like most organisations would, where you'd be like, okay, well, in my operating bit, what can I do to help this problem to meet my idea of success? What we wanted to do in this project was think holistically. So this is an approach known as systems thinking, where essentially we say systems are composed of a series of interconnected components, and these the interconnection of these components results in a series of feedback loops. And so this can cause policy resistance, so we can implement a change and nothing happens, or unintended consequences. So maybe we change something up in this bit of the system and something we never expected to change in another bit kind of pops up. So we want to create a model that kind of captures that to help guide our decision making. And there are examples of this. I just put this kind of change by design header up. There are examples of this all across healthcare. The other reason I think that this is particularly important in this business context is it stipulates the behaviour of a system is driven entirely by its structure, which we have to produce. So that means it's very transparent. It's not black boxy. And we all kind of have to be on the same page about what's going on with blood collection. So what do we want to do with this model? Well, we want to put it as essentially the back end of a scenario planning tool. So these are just some screen grabs from different scenario planning tools that exist. So scenario planning tools are just low risk, low cost bases to test what if questions. So the idea would be, if you look at the climate one on the top left, there are a bunch of parameters that these stakeholders have identified as important to climate policy change. Across the top, you've got the 3 KPIs they're interested in, global source of energy, greenhouse emissions, temperature, and they can toggle all those things and get a sense of how that might impact their key performance indicators. And so this is what we'd like to do really, is understand the potential impacts of the levers that we might pull on our key performance indicators prior to a pilot or wider implementation, because these kind of have costs associated with them and they detract from the capacity of the system. So it's not always appropriate, even though that is the gold standard for kind of establishing causation. So we're not aiming to perfectly replicate the system. It would be highly simplified and tailored to our business question. But hopefully it should allow us, kind of help inform some of our decision making going forwards. So we could look into things like, okay, well, if we want these new, if we increase new donors, how does this impact KPIs we care about? So that's things such as how often donors donate, things we care about like conversion rates, so appointments per donation, donations per appointment. We can establish, okay, well, if we implement a strategy and a metric we care about changes, is that a good measure for success? Is that something that we now no longer need to worry about that we used to be worried about before? We can establish perhaps how many new donors we need to sustain our program, what resource more widely we might need to support that, so we can see when our targets are misaligned across the organisational setup, and do some work in workforce capacity, which is how this technique is traditionally often used. So just to summarise, so the language is clear. Systems thinking is this framework for understanding complex systems, and we're kind of defining blood collection as a complex system in this situation. And systems dynamics is a quantitative tool for modelling those systems. So it's a kind of branch of simulation that overlaps with this kind of systems thinking idea. We're using systems dynamics for a bunch of reasons that I've mostly mentioned around the fact we want a really holistic understanding of the blood collection system. We have strategic questions. We're really curious about feedback loops, and we query the relevance of historic post-COVID data because our operations have changed a lot. There's also a bunch of technical reasons if you're kind of in a space where you're considering simulation. We have large volumes of data, which would be difficult to handle through some other simulation methodologies. We have a lot of data gaps, so we need something with a high assumption tolerance. And there's a lot of support available within the current NHS system, which I think is really important just to highlight. This isn't necessarily a technique we had in-house, and so it's been really great to have the NHS demand and capacity team in particular really support us and kind of help us on this journey. Systems dynamics, generally speaking, will be represented like this. So I won't show you many diagrams, but I just kind of wanted to flash them up so you weren't kind of bamboozled later when they come up. But essentially, systems dynamics considers all the stocks within a system and how they change over time. So if we think of population as the stock of people, that only goes up by births and it only goes down by deaths. Similarly, something more familiar to you guys would be this one on the bottom, where we think about a very simple pathway. Say we're interested in waiting lists, it only goes up by referrals and it only goes down by admissions. Similarly, inpatients only goes up by admissions and down by discharges. So this is a kind of diagram you might see further in the talk. So this is just a summary of that. In order to be able to build this space that we can use to get our end users to kind of test their strategic decisions, we kind of had to go through these 3 stages. So we needed to first map the blood collection system. So I think it's something that feels really silly because every one of us thinks we have a mental model of how our own system works, but that is a personal mental model, right? So if the blood collection system was like a painting, it's almost like we're all looking through a board and our own holes. And so we only see a bit of it, we have our own biases. And the idea is if we get everybody together, everybody explains what they can see, then we can begin to perhaps replicate something that actually more holistically represents what's actually happening. Then we have to do a data audit to be like, do we actually have the data to build this model quantitatively, or is it just a concept? And a bit of exploratory data analysis to establish whether what people told us was happening is what's actually happening. We'll then try and model the business as usual conditions, and then policy changes, which we're not onto yet, which is why it's tiny and in italics. Again, just for anyone that's not familiar with this approach, very iterative. So we're starting with this all blood type, low resolution, operationally focused model. The idea is once that's working, we can add things that are important to the organization. So we can stratify by blood type, then by donor type, and then by perhaps some more specific controls of our booking systems. So we started with those interviews. They were really simple. We just wanted to know, how is your team trying to achieve, how do you measure success? What are you trying to achieve? Can you describe the system in terms of how we might regulate it and how the external environment regulates it? And is there anything we should know? And we ask people across, our setup is very much, we have a lot of multi-team functions, so we just pick people out of a variety of different teams, predominantly under 2 directorates. And this is just a sample of some of the qualitative findings. So we found people, for example, did have a lot of consensus on the things that impacted whether or not someone would give blood and how much blood we were able to collect. But there was perhaps less of a consensus on how these levers worked and when to implement them. So something that this system can help us kind of align on. What we also saw, which you'd perhaps expect, again, from siloing, which I'm sure being in the NHS you'll be familiar with, is this siloing had led to different definitions of success across teams, which had resulted in some conflicting actions across the supply chain. So at the top of the supply chain, if we think about the teams responsible for registering people, and you may well have seen the content, we talk a lot about we need new donors, it's really important you come and donate, and there's lots of money spent on increasing registrations. But because we have this constraint on collecting enough blood to meet our demand requirements, and the downstream teams prioritise sufficiency of supply, there's actually a really big concerted effort to remove those people from the system, which is a big conflict. And this means, sorry, these people get cancelled or they can't find appointments. Those 2 things are our biggest cause of complaints. So that's very jarring for the donor. And whilst it's okay in the short term, could potentially have some long-term negative kind of implications, which is essentially what this is saying. So I didn't go through causal loops earlier. Sorry, that was a mistake by me. I forgot this was here. But essentially, one of the things we were pulling out was what are the short, medium, and long-term things we do. So, yeah, I don't think you can. Okay, so if we aren't collecting enough, so there's a gap between the collections we get and our desired collections, what we tend to do is increase our grid size, which is the number of appointments. This results in an increased number of bookings, but if we don't increase capacity, then that increases schedule pressure. Because of overtime, this actually does work in the short term. Similarly, because of the pressure, you do get more donors through. So the initial response here is we do get an increase in collection. So the little positives, probably can't see them, a positive relationship. If one goes up, the other goes up. However, if you keep doing this, and I mean, it's quite intuitive, you get fatigue, which results in staff loss, an unwillingness to do overtime. This leads to cancellations, which in the kind of more medium term result in, in the short term, reduced collections because that person doesn't donate blood. And then in the longer term, we don't know what impact that might be having in terms of that donor coming back. So just something for us to think about in terms of, whilst we might need to do this in the short term, perhaps we need to do something more sustainable to maintain our workforce and kind of good donor opinions of the service. We then did the data audit. So this is what data do we have, what's the quality, when we kind of run the analysis, do the numbers reflect our interview findings. Like, again, all of you guys, we work with an operational data source. So even if we just wanted a row of data that said, for this booking, what happened? This is the number of cables we would have to join together to get that. So it's just kind of quite an ongoing operational challenge just to flag. Because of that kind of breakdown and how data is split and stuff, we had some data more readily available than others, and that guided what we proceeded with. So the model I'll show you is really focused on donor flow and blood supply, but less focused on operations and planning for pragmatic reasons, but they do need to be built in going forwards. Yeah, so this is, sorry, just reiterating that our boundaries of the model, and it's something I think we touched on in another talk, what do we include and exclude in the model, because all models could go on forever. What do we simulate in the model, or what do we just tell it, and what do we actually simulate? This is highly governed at the moment, a bit by a business case, but mostly by data availability. So we're only simulating collection numbers, cancellations, blood stocks, the size of our donor base, and what we issue. So I won't dwell on any of this because I think it's a bit context specific, but we did have a look at the different things that influence whether someone was likely to donate at an individual level, because it was a challenge we received a lot. So people really like machine learning at the moment, I'm sure you're all aware, and so there's a real demand for can we predict individual appointment outcomes at the individual appointment level, which we can't really do, but there are some things that influence donation likelihood. So if you've donated over 50 times, you're much, much more likely to donate blood than if you've never donated. But I think what's important is some of this is within our control as well. So you're much more likely to be cancelled by us, 3.5 times more likely if you've never donated before. So if we wanted to increase new donors quickly, we probably could. But other than that, not a lot of individual variables influenced donation likelihood too strongly. Similarly, I won't dwell on this at all, but just to say we looked into different levers, such as that grid size thing I was talking about, cancellations, to see do any of these seem to have a causative relationship or any kind of relationship with our performance, and they didn't particularly, suggesting they might not be the most effective levers. Same with seasonality, I won't go into it at all. We do have some seasonality issues that we know of, particularly around Christmas. But we tried to build as many of these different, this is just to go, we did look at some things. We tried to kind of build as many of these things into the assumptions and data underpinning the model as possible. What we end up is something that looks like this. So what I like about it, I won't go into any detail, one, because you can't read it, and two, it's massive. But the key point is very transparent. So the structure, like, it shows every assumption, and we have a supporting document that if you're interested in, okay, well, what assumptions have you got into this rate? Like, how did you calculate this competition? It's all really open, and the idea is that stakeholders can tear it apart. Like, we want them to tear it apart. We want it to be robust and a real reflection of the system. Yeah, the key points of how it generally works. So we've got sections on donors, so registrants donating for the first time, they kind of go through this process of recovering and then going from being considered an active donor, which is somebody who's donated quite recently, to a lapsed donor. So kind of you've got unit points here. We've also got a section of the model on forecasting our own collections and processing. We didn't want to have this in scope originally, but we found that a lot of operational decisions were made on the basis of our own stock levels. So we kind of had to add that into scope, which presented a lot of practical challenges, I think. I don't know if you've had a model that had to absorb a new directorate partway through, but it was quite challenging. So yeah, that was kind of what we've got with the model. What the model can do at the moment, based on some simple assumptions, is replicate the historic behaviour. So the blue line, I believe, is a simulation, and the red line is what actually happened. So with blood collection, it's quite similar. There's a big gap in issues, behaviour and stock levels, and this was that amber alert we talked about. So we did something actually quite unusual at that point, where we stopped issuing blood at the same rate. So quite relieved that this split at this point, otherwise that would have been a bit weird. So yeah, so it's a kind of positive start point, but it doesn't simulate as much as we would like it to at this point. We've also started splitting that down, as I said, according to things like blood type, so it becomes again a bit more nitty-gritty as the groups themselves get a bit smaller. The last bit of the journey was, so I probably should have said this up top, I did this as part of a data science project. So my background, I'm a developmental neurobiologist by training. This is my first kind of venture into operations. So I did this in quite a siloed way. And we found, as I'm sure maybe some of you have found, it was much easier to get people to buy into taking some time out to discuss the model when we had like a little toy we could put in front of them. So the idea was that this would be that minimum viable product kind of toy, and then they could kind of play with the sliders, see how key things change, and we could develop the model then much more tailored towards what they need. And that's been quite successful. I'd say now that we have something to show people, they're a lot more engaged with it than before when it was a bit more abstract and a bit more of a concept. So yeah, next steps, we want to refine the model, build those iterations out. We've done a couple of internal talks, which has helped refine the use case, and we're now going to use it in some business planning to make sure our targets are aligned across the system. So at the moment, targets are a little bit more operationally siloed. So sometimes we have targets that are incongruous, so they can't kind of coexist and both succeed. So it'd be helpful for kind of pulling those issues out, and then hopefully we can build the depth to answer a few more questions. I don't think I particularly need to go into this, but what I will say as like a last point, because I wasn't really sure who the audience would be, is a couple of reflections, I guess, on doing research within the NHS, but also using systems dynamics if you're in the NHS and haven't done research. You haven't done, sorry, this technique before and are considering it. So I have found them to be like the most supportive community ever. So I would like really have a go at doing some systems dynamics modeling. I have found it requires a really strong mindset shift because you no longer think about the individual, but the flows. So for me, I found it really useful. I found that, as you could probably tell from the focus, the qualitative side of it was really interesting and actually more operationally useful than perhaps some of the maths, which I think is unusual for a data science project. But we did have some issues that we are currently dealing with. So I think there's an issue around some of the data quality, it being sprawling and operational and little documentation. But we are now investing in kind of a data lake and a kind of an environment and infrastructure that should hopefully overcome these problems in the future. And it's been good to be a part of this project and also that project and kind of bring those things together. So hopefully we have a richer data source for the future. So yeah, with that, sorry I sped through and spoke so fast, but I'll just acknowledge my team. They've been really supportive in letting me go off on this jaunt on this random technique. Demand and Capacity, who have just been phenomenal. And yeah, the DAS team that worked with them and my university. Thank you.